Good morning or good afternoon, depending on when you're deciding to view this presentation. My name is Melissa Stewart, and I'm a student at Northwestern State University working on my Doctor of Nursing practice. Today, I would like to present my Vulnerable Population Project to you, which focuses on obstructive sleep apnea in the morbidly obese population. Obesity and sleep apnea as a vulnerable population. It is estimated that there are 78.6 million adults who suffer from obesity. That is roughly 1/3 of our population. Current screening measures for obesity include a BMI and/or a waist circumference. In order to be diagnosed with obesity, one must have a BMI greater than or equal to 30. Whereas to be diagnosed as morbidly obese, one would need to have a BMI greater than or equal to 40. Research has shown that obesity is directly related to certain health problems. These health problems include coronary artery disease, cerebral vascular disease, diabetes, certain cancers, hyperlipidemia, and insulin resistance. Obesity has also been shown to cause an increase in inflammatory markers. In dealing with obesity, there has also been shown to be a decrease in years of potential life lost. The U.S. has a predetermined death age of 65. Any death prior to the age of 65 is considered to be premature. The actual age of death and the death age of 65, the difference between those numbers is what we call the years of potential life lost. Current medical cost for obesity is roughly $147 billion. This does not include productivity lost because of obesity. That is estimated to be at $3.38 billion to $6.38 billion. Sleep apnea. We are unable to determine the exact number of patients who are undiagnosed. However, it is estimated that 80% of all patients who have a moderate to severe sleep apnea are undiagnosed. The screening for sleep apnea currently consists of an Epworth scale and a stop-bang scale. There are health problems that are directly related to sleep apnea, just as there are health problems directly related to obesity. Problems related to sleep apnea include coronary artery disease, congestive heart failure, COPD, hypertension, depression, erectile dysfunction, and cardiovascular disease. It is estimated that untreated sleep apnea causes $3.4 billion in healthcare costs per year. Again, that is an estimate since we do not know exactly how many people are undiagnosed. Health disparities and obesity. Obesity is noted to be lowest in the white population versus the African American and Mexican American population. The highest level of obesity is noted to be in the African American females, whereas the lowest level of obesity is noted to be in Mexican American males who are less than 20 years of age. Limited differences were noted in obesity in males greater than age 40 despite race, ethnicity, and socioeconomic status. There was an inverse relationship between income and obesity in white males and females. However, other races have a positive association between income and obesity. Causes of health disparities include lack of education, lack of physical activity, poor food choices, and high cost of healthy foods. Health disparities and sleep apnea. There is growing awareness that poverty and social disadvantage are associated with sleep disparities, and that sleep disorders have a disproportionate impact on those who reside in poverty. Sleep disorders are thought to be more prevalent in persons who are of lower socioeconomic status and in those who have limited access to health care. Unfortunately, socially and economically disadvantaged persons have the greatest barrier to health care access. Sleep disorders are known to cause or influence behavioral and performance deficits. These deficits occur in the home, work, and school environments. Sleep apnea is also associated with diseases that cause health disparities. Unfortunately, the contribution of obstructive sleep apnea to healthcare disparities is largely unexplored, and the causes of disparities related to sleep are just now beginning to emerge. In 2011, the National Heart, Lung, and Blood Institute did a workshop specifically to discuss health disparities as they relate to sleep problems. One of the goals of Healthy People 2020 is to increase the number of persons who have symptoms of obstructive sleep apnea who see a provider for this problem. In conducting research for the development of the PICO question, certain facts were noted to be of utmost importance. The first is that obesity is a major risk factor for the development of obstructive sleep apnea. Also, sleep apnea is highly underdiagnosed. Also noted was there is very little knowledge related to the prevalence of obstructive sleep apnea in patients who are considered to be morbidly obese. Next, data is not clear on screening processes for obstructive sleep apnea in patients who are morbidly obese. This lack of knowledge led to the following PICO question. Will the implementation of obstructive sleep apnea screening in all patients with a BMI greater than 40 lead to an increase in accurate diagnosis as compared to screening only patients with symptoms of daytime sleepiness and or snoring? The interdisciplinary plan will include all medical staff. The medical staff consists of the medical assistants, the LVNs, the nurse practitioner, and the physician. The plan itself is very simplistic in that when a medical assistant or LVN brings a patient to the triage room, they will also obtain a BMI with vital signs. If the BMI is shown to be greater or equal to 40, the patient is considered to have morbid obesity and will be given an Epworth screen. The provider will review the Epworth screening and look for a certain score. Scores of 12 or higher on the Epworth will constitute a positive screening, and these patients will be referred for a sleep study. Scores of 9 to 11 will be considered borderline, meaning they need additional data. When this occurs, the providers will look for certain lab markers that correlate with sleep apnea. As we said previously, sleep apnea does cause increases in certain inflammatory markers. Markers that will be looked at will be a HS-CRP and a cortisol level. When these levels are noted to be elevated with a score of 9 to 11, patients will then be referred for a sleep study also. Stakeholders. Stakeholders are basically any individual, groups of individuals, or organizations that have an interest in your project or in your research. There are 4 main questions that you can ask to help decide who your stakeholders are. The first question is, who will be affected by this program or by this research? The second is, who can influence this program or this research but not be directly related to the development, implementation, and evaluation of the program? The third is what group is interested in the program or the research, its success and its outcomes. And lastly, who will be or could be impacted by this program or by the research. When we apply these 4 questions to our research, we notice that our number one stakeholder is our patient or our client. They're the ones who are being affected. They are the ones that can influence the program. They're the ones who are interested in the outcomes and the success of the program. They are the ones who are going to be impacted. Also, the providers. The providers are stakeholders in that we are very interested in the success and the outcome of this plan. We want increased diagnosis of sleep apnea, therefore reducing all the comorbid problems that go along with it. Other stakeholders are the medical staff. The medical staff are stakeholders in that they are the ones who are implementing the program. They are the ones who are giving out the Epworth. They're the ones that it can influence the plan and the program. DME suppliers, these are the people who are going to supply your CPAP machines if your patient has sleep apnea. They're very interested in the outcomes because it will mean increased revenue for them. And when we think globally and largely, the American Academy of Sleep Medicine could be interested in this program because it does deal with sleep apnea and it could affect how we screen patients for OSA. Unfortunately, with all great research proposals, there are challenges that have to be identified. In this proposed project, the challenges that were identified were, number 1, lack of education. This lack of education could be regarding the purpose of the plan and or how to implement this plan. In order to overcome these challenges, there need to be clear policies in place of how the plan should be implemented and what to do if a problem arises during the implementation process. Also, it is very important that the staff understand why the plan is being done. In this case, it is very important for the staff to understand the significance of obstructive sleep apnea and the risk it plays in your overall health. If we provide adequate knowledge, we can limit those challenges. The second challenge that can be perceived is data collection. The data collection for your BMI and for your Epworth score. It will be imperative that the medical assistant or LVN get accurate heights and weights. A stated weight and a stated height will not be acceptable. They have to have a physical height and weight done. This is going to be time consuming for the medical assistants, so we just need to, again, provide education as to why this is important. A BMI of 39 versus a BMI of 40 is either in or out of the proposed research project. Also, adding up the Epworth scale. It is imperative that we get an accurate number on the screening. An 11 versus a 12, an 8 versus a 9. It can also play whether you're in the proposed plan or if you're not. We can overcome this strictly by having the provider re-add up the score. It takes no time and it provides a double check. BMI also can be easily calculated through an electronic medical records like eClinicalWorks. So it all comes down to getting an accurate height and weight on that. The third potential challenge is client's participation. This is where I perceive to be the biggest problem. Clients who feel that they sleep well, who do not feel that they're having any kind of symptoms, may not be willing to even do the Epworth scale. Therefore, it is very important, again, to provide knowledge to the patients as to why we're doing this and that they understand that sleep apnea is undiagnosed and can be contributing to their obesity. Again, knowledge is key. Providing that ample knowledge, hopefully we can increase client participation. With every proposed research plan, there needs to be some type of method to measure the quality and effectiveness of the plan. For this program, I have decided that the best way to measure will be through the HEDIS framework. This looks at effectiveness, accessibility, availability, satisfaction, use of service, and cost of care. For us, we're going to know how effective was this plan. Was the increase in diagnosis of sleep apnea made? Did increased screening help at all? Was it beneficial? Was access to Epworth easy? Was it easy to understand? Was access to sleep studies easy? Is the client satisfied with the care they received? Are they satisfied that they received a diagnosis or did not receive a diagnosis? Look at the use of the services they used. And again, was cost a factor? Unfortunately, cost plays into because not every insurance company is going to cover a sleep study at 100%. It may be of the patient's responsibility and they may not be able to afford a sleep study. So then we still do not have that accurate diagnosis that we need. However, I think the best measurement tool for this plan is the HEDIS framework. Use of technology. More and more people today are using technology than ever before, especially to access information regarding their health. It is of utmost importance that we as medical providers provide patients with reputable websites. In regards to sleep apnea, reputable websites would include the Mayo Clinic, the American Academy of Sleep Medicine, and Medscape. Another use of technology is the use of electronic medical records. The use of electronic medical records allows for easy transfer of information between providers, between provider and DME companies. Another use of technology is appointment alerts. These appointment alerts can be done via text message, automatic phone calls, automatic emails. They're very important for patients to keep their follow-ups, especially when they are in a study. One thing that I'm very excited about in regards to technology is the home sleep studies. Home sleep studies are very easy to use and provide almost instant answers to whether the patient has sleep apnea or not. The patient simply does a sleep study at home, brings the sleep recorder back to the office, the chip or card is downloaded directly in the computer, and we have results. Also, in regards to sleep apnea, we now have recordable CPAP machines that allow us to check compliance with patients on CPAP. This lets us know, are the patients using the CPAP? How many hours are they using it? Are they still have an increase in their AHI, which is their apnea-hypopnea index? What is their oxygen saturation doing? This way we can know, is the CPAP the right medical device for this patient, or would they be more apt to have a BiPAP machine? Technology is ever growing, and it is amazing where we are and where we are going. In summary, we know that 1/3 of all adults suffer from obesity, and that 80% of persons who have moderate to severe sleep apnea are undiagnosed. Both obesity and sleep apnea contribute to high medical cost. We also know that little knowledge and research has been done regarding obstructive sleep apnea in the morbidly obese population. Therefore, further research and improved screening methods need to be accomplished. The plan is to basically administer an Epworth screen to any patient who has a BMI greater than 40. Our ultimate goal is to increase the diagnosis of sleep apnea, get patients treated for sleep apnea, and decrease the comorbid problems that go along with sleep apnea. Here are a list of my references. Here are a list of my references. This is the conclusion of my reference list. Please feel free to ask any questions that you may have and provide any advice. I promise I will take it all. Thank you. Have a blessed day.